It's good to be with all of you. It's a real pleasure for me to be part of this event. I've long admired SCES when I first came to know about it, but to have the opportunity to speak to you all here in this way is just such a thrill and a pleasure. And I have to say, I mean, you know, Marta, you described the challenges that we face at this particular moment. I too live not far from DC, and coming up here is sort of a breath of fresh air and a real welcome opportunity to actually be present among all of you who are really solving problems that are materially present in our patients' lives, in our communities, members' lives, et cetera. But really what I was sharing with Marta last night she very gracefully welcomed me after I got out of the airport and spent some time, even though she'd already eaten dinner, but hanging out with me and talking to me about, you know, what SCS is doing at the moment. And what I learned as I was talking to Marta was this tenacity that she has and that this organization has to see through the present moment of challenge to actually ways in which we can innovate our ways to a different place, a better place overall. And I was remembering, and I said this to Marta yesterday, that I had a running coach a long time ago when I could run properly. And that running coach actually gave me this lesson that has stuck with me for my whole life. On some level, it's been 30 years since I heard this piece of advice. But what he said to me at the time was that progress does not wait for perfection. And the notion here was that, you know, we will deal with imperfect circumstances our entire lives. And it is in the moment of imperfection, in fact, that you make the most progress. And to be clear, this is a moment of significant imperfection in our world. And especially for the patients and family members and community members that all of you look after and serve, whose safety net is being unraveled and threatened. I won't sort of be politically appropriate here. I think we are under a great deal of duress and stress as a nation and as a community. And at this pivotal moment, when we are when the conditions are deeply imperfect, to make progress, to create the new in the midst of this storm is sort of the beauty and the strength of what SCES is doing. And as I talked to Marta for about, I don't know, an hour or so over my swordfish and her, you know, Brussels sprouts or something that you ate last night, she told me about all of the ways in which SCES is innovating and pivoting and adjusting and iterating on the present moment, which is brilliant and breathtaking at the same time. All a product of the moment of imperfection that we live in today, but something that I think that a lot of people could learn from around the country for sure and around the world. So I want to say, before I say anything else, thank you to all of you for showing us how to actually innovate and make progress during a moment of intense imperfection. So I'm going to talk a little bit about aging and designing the future of aging, but I'm going to also talk a little bit about action. I understand that my good friend Rishi Manchanda was here last year. I've heard from the staff of SCES, who has been amazing during this entire preparation period. I see you sitting here in the front row, Colleen, so I'll call on you. But about the brilliant work that Rishi did, sort of highlighting the nature of the interconnectedness between health and social care, going upstream, as he likes to say, so that we can solve some of the social determinants that actually precondition health outcomes in our world. What I want to talk about today, as Marta alluded to, is the notion of how we actually take those ideas and implement them successfully, and not just for one patient at a time, although that is how you do it in that beautiful story that you told earlier, but also how we scale these ideas. How do we get them to everyone who needs them everywhere? Because that is the challenge that we face. I know that the people in this room can take care of a single older adult, or maybe even a dozen older adults, or maybe even 100 or a couple hundred older adults. But what I don't know is if we can get to all 65 million older adults in this country that need the kind of care and attention that they deserve, that everyone should have access to in some way. So I start with this notion here, and this is the sort of starting with why kind of slide. Why are we here? And if you haven't seen this TED Talk, I think many of you probably have, but it's worth a 10-minute or 15-minute watch. Simon Sinek, an author and speaker now, did this sort of brilliant talk, 15 years ago or so on the TED stage about why it's important to start with the why. And in the talk, he describes how the greatest companies and the greatest organizations in our world know their why very well. And most companies know what they do or maybe even how they do it, but very few companies actually know why they do what they do. So when we started Age Friendly at IHI, now almost a decade ago, we started with our individual lives. In the very first meeting of age-friendly health systems, when we were building the approach to elder care that we eventually scaled, which I'll show you in a minute, we all started with telling a story. And for the first time I told this story, it was totally impromptu. I didn't understand that we were going to be doing this, but this is the story that I told. I told the story of my grandmother, because my why for Age Friendly starts with her. So this is my Aji, Suman Thakurdesai. She, at the time of this picture, was probably in her late 70s, early 80s. Suman, my Aji, lived in Bombay, India, and she grew up in a family where girls did not learn how to read. She was the first in her family, the first girl in her family to learn how to read. She was the first girl in her family to go to high school. She was the first girl in her family that got a job, which at the time was very, very unusual for her to have a profession, have an actual job. And she got that job in the post office, which may sound somewhat prosaic, but it was like incredible for someone of her upbringing to be working in a government position, which in India is like security. You know, this is a position she could have economic security forever. It turns out it was also a really important moment for her because she met her future husband and my grandfather in the post office. He was a mail carrier and she was the mail sorter. So they would meet, I guess, and fell in love over, you know, dispensing the mail. You know, I have this sort of romantic notion of how this all transpired in my head. I actually don't know exactly how it worked, but anyway, this is my image of it is her sorting and him picking up the mail and carrying it off. Love marriages, as they're known in India, were super uncommon back then. So for her, not only to have broken all these other barriers of education and job and profession, but to then go against her father and mother, but specifically her dad, to enter into a love marriage with my grandfather was super controversial. Anyway, she when I, of course, got to know her much later on after this story, she was sort of like a dedicated, hardworking person. She'd been that her whole life. What it meant for her to be a hardworking person in her late 60s and early 70s was to cook meals for the family and to hang the laundry. She taught me how to actually do laundry, not with a machine, but with like a stick and soap. Thankfully, I don't have to do that anymore. But anyway, she was sort of this person whose by nature was her primary purpose was to serve her family, and that's what gave her joy. That's what made her who she was. As she got older, she suffered from frailty. She got older, severe osteoporosis. She had vertebral compression fractures in her spine. It caused her a lot of pain and disability as she got older. She was able to ambulate, but she got it became much harder on her. And then one day I was in South Africa, actually, at the time. I was working on a TB program at the time, tuberculosis treatment program. That's what I was doing with Partners in Health. And I got a call from my mom, and it's the call that I think all of us probably dread. It's the call that says, you know, your grandmother, my mother herself, distraught, you know, crying through the phone, telling me that my grandmother was likely not going to survive for much longer, and that if I wanted to see her, I should go now. And so I immediately dropped whatever I was doing, got on a plane, which thankfully I was halfway across the world already, and got there within 12 hours or so. And when I walked into her room in the house, they lived in a very modest apartment in Bombay, 2 rooms. So one room was the kitchen / living room, the other room was the bedroom. And when I went into the bedroom, the curtains were drawn, you know, the candles were lit, the prayers were being sung. You know, she was lying sort of prone on a bed, sort of barely registering what was going on in the world around her. And I came in and did what I do, which is to touch her feet. That's the Indian sign of respect. Touch her feet, say I'm here, whispered in her ear that I was there. She sort of acknowledged me at the time, but I can't actually tell that she really acknowledged me. And, you know, I'm a physician, sorry, so I had to start. It took me like 5 minutes of like greeting her and being in her presence before I started asking clinical questions about her situation. Like, what kind of medicines was she on? What was her pain control? You know, who was her doctor? When did she last see him? You know, et cetera, et cetera. So and then I went to make a field trip to her doctor, which he loved. And so the field trip consisted of me basically grilling him, and he was this sort of like annoying US doctor coming to tell me how to practice medicine. And I was asking him questions about like, pain medicines and diet stuff. She was very depressed towards the end because of her ailments, and she couldn't do the things that she enjoyed doing. And at the end, he told me that he got really upset at me. And he was like, listen, buddy, you know that she's like 82. And I was like, yes, I know she's 82. And he was like, well, people in India die at 82, right? Old people do not live any longer, and you have unreasonable expectations for old people in India. And I was like, whoa, yeah, exactly. I was like, what? I mean, I didn't smile at the time. I was like really pissed. So I left his office and decided that I was going to be her doctor. So I stayed there for 2 weeks. And because India has somewhat relaxed prescribing rules, I became her clinician, right? So I put her on a pain control medicine regimen. I put her on an antidepressant. I put her on an appetite stimulant. We found a physical therapist, which is sort of hard to find there. And sort of they got her up and moving around a little bit. And within like 2 weeks, my grandmother, who was dead, more or less, or my parents thought she was dead, or everybody thought she was dead, she was up and moving around and climbing stairs to go to her favorite spot to go. Thank you. Not heroism by any means, but like just appropriate treatment that wasn't fundamentally ageist, right? Which is essentially what I was dealing with the guy. So I put this up here like as to what I think happened in this moment, right? People underestimated her. Her doctor did. Her family kind of did as well. Evidence. There was no. It was evidence-free medicine. I would say it was being practiced. Complaints. Our family's complaints. She didn't want heroism. What she wanted was to get up and chop the vegetables on the floor as she'd done her whole life, right? And to throw the laundry over the little thing that she threw the laundry over. So this is, I think, one story, and this was part of my why for why I wanted to start and work on age-friendly health systems. Interestingly, a couple years later, my wife's mom, my mother-in-law, who's pictured here, had a health experience. And her experience was sort of fundamentally different than what happened with my grandmother. So my mother-in-law, also an older adult, in her mid-70s in this picture, and now in her 80s, had a diagnosis of leukemia. And she, kind of out of the blue, she's had other health issues her whole life, but about 4 years ago, she was diagnosed with leukemia, and she was given 18 months to live. She met her cancer doctors in Virginia, where she lives, and they started her. They offered her a medication based on the evidence that was available, but they also said there was a trial at Hopkins that she should potentially go look into for an experimental medicine that might extend her life. She went to Hopkins. She was taken there by this is kind of a true story. Her cancer doctor in Richmond, Virginia, drove her to Baltimore she didn't need to drive her to Baltimore, but she did, to go visit this other physician. The other physician, who was marvelous, started her on this new medication. And we arranged for a home health aide, through the local services organization that was present, somewhat similar to SCES, that's present in her community. She has a visitor there now that helps her prepare her meals. When she's on a chemo week, she basically can't do anything. She lives in a house where she has to go upstairs to get to her bedroom, so they installed a thing, the stair thing that got her there. And she not only survived the 18 months, but it's now been 4.5 years, and she is still alive and doing well. Thank you. This story is a fundamentally different story than the first story, right? Coordination here, almost unbelievable, I would say. Like, a doctor driving a patient to another doctor, like that just never happens, right? It's pretty wild. Evidence kind of implemented in real time, right? It's not evidence-free. They're like literally testing the boundaries of what we know and applying knowledge directly to this patient's life and care. This idea that complaints, her issues, it was very interesting. The original offer was to give her a bone marrow, I forgot this part of the story. The original offer was to give her a bone marrow transplant to cure her leukemia. And I, of course, was super excited about this because it meant the possibility of her being cured. When she went for her lung function test, you might remember there was that one day, like it was a Wednesday a couple years ago, when the Canadian forest all lit on fire at once. And there was this giant orange cloud that sort of went down the eastern seaboard, and like New York looked like hell, basically, and maybe it is hell anyway, but it looked like it is, and I'm not sure exactly what it looked like here, but that was the day that she went for her pulmonary function tests. And guess what? She failed them. She failed them royally, and the interesting thing about it was when she failed them, her Hopkins doctor said, I'm sorry, I cannot offer you a bone marrow transplant. It will kill you, right? You will not survive this. And her reaction to this was utter relief, which I did not know. Like, I did not know that she was so scared of this possible treatment and that she fundamentally did not want it. What mattered to her was not getting a bone marrow transplant, in fact. What mattered to her was continuing on the chemotherapy that she was on. And she managed to do that and now has survived for many years after this and is doing quite well. So what changed between the time of these two stories? There's a lot that changed, but I think one aspect of what changed is we became much more sensitive to this notion of age-friendly healthcare. And I credit Terry Fulmer. Many of you know Terry, I hope, and if you don't, you should, because Terry Fulmer is herself another force of nature. Terry, a researcher, a nurse, leader of aging. She was the president and CEO of the John A. Hartford Foundation. And Terry's frustration, which she has spent a whole life of studying geriatric medicine and improving care for individual patients, one at a time and a time and a time. And the most scaled program that she knew of was PACE. And some of you know PACE. I talked to some of you about PACE earlier today. And PACE, at the time in 2016 when we were doing this work, PACE had reached about 5% of the total population that it needed to reach. So not scale, I mean, amazing program, but not yet scaled to the level that it needed to scale. And that was Terry's frustration. It was, we need to do something else. If we looked at all of the major geriatric programs at the time, PACE, niche, the health program, all these sort of geriatric acronyms, there's a lot of those in medicine, that are doing well to take care of older adults. If we looked at them, we summed all of their beneficiaries, which we did at IHI, we summed all of their beneficiaries, it was about 10% of the older adult population in the country. So PACE being the largest, but still nowhere close to how many people we needed to reach. And Terry's vision was a movement. She was like, we can't do this one program at a time. We need to get to a movement where every older adult has the benefit of a better system, one that's guided by evidence, one that doesn't cause harm, one that actually understands what matters to older adults. Like, she heard the story of my grandmother, was like, we can't have that any longer, right? What will be different? And we had these aims, these goals of getting to 1,000 care locations in a year. So this was 2016. We wanted to get to 1,000 by 2017. So the goal was like, scale quickly, right? Don't intentionally put forward an aim that you're likely to fail at doing. That was a bit of the kind of construct that we were using. And this was the sort of approach. We had to find evidence. This, of course, is the story of aging in the United States. You guys know this story very well. Demographically, aging rapidly as a country, and will be an important aspect of our future in this nation entirely. Complexity, 80% of older adults experience multiple chronicity, and also have a significant proportion of them also experience social needs that are solvable only by organizations and governmental and parastatal organizations like SCS. And they also experience disproportionate harm. They experience the system more, the health system more, and so they're injured by the health system more, unfortunately, just as my grandmother was back in India. And so this is the constellation of factors that leads to, unfortunately, not great care for older adults and inequitable health outcomes for older adults today. So we decided to compose a way of thinking about this, leveraging the best of what we knew in the science. When we did this, we actually studied all of the evidence-based practices that were present, and we looked at specifically 17 evidence-based care models with level 1 and 2 evidence. These were randomized controlled studies, et cetera. And we found all of their active ingredients. This was the way that IHI does this, is they distill out all the active ingredients of all these programs, And we found the ones that, there were 90 features, but when you looked at all the redundancy across them, lots of them focused on medications, lots of them focused on mobility, and lots of them focused on cognitive issues. And we asked in an expert meeting in August of 2016 for the researchers and the community of geriatricians to only pick 4 things. You couldn't have 13 things. We knew that at IHI we could not scale nationally all 13 elements. We needed to incrementally get there. We could add later, but we had to start with the vital few in the beginning. And we got to the 4 M's that you see here in this slide. The 4 M's are what matters to older adults. Probably the most important aspect of this whole thing is really understanding what older adults want, need, and how to get it to them. Medications, really reducing polypharmacy and sort of improving the way in which medications are used in an older adult's life. Understanding how to work on their mentation, cognitive status, that included depression in the ambulatory setting, delirium in the inpatient setting, and dementia in both settings, so the 3 Ds, if you will, of mentation. And then focusing on functional status, making sure that people had the appropriate level of mobility and functional status to achieve their other goals, whatever they might be. And these 4 M's were, they were synergistic, they interacted with each other, they emphasized the core elements, they also were scientific and evidence grounded. So these 4 M's became the kind of calling card of age-friendly health systems around the country, and again, distilled from the evidence. I'll give you the punchline up first, because this is not meant to be like, I'm not holding you in suspense, but the program has been enormously successful. Every target that we had to get to, 1,000 by 2017, we got to 1,600, within a year. We set a new bar of 2019, get to 2,500, we got to 3,200. We set a new bar of getting to 4,000 by 2022, we got to 4,200. And the latest bar is by the end of this year to get to 6,000, which I'm quite confident that they'll get to at the pace that they're going. They add about 300 sites a month. So this was in March. So there's a lot of, they will get to this goal by getting to more than 6,000 sites. And the more important one is this, like almost 6 million older adults now have been treated and cared for by systems that are age-friendly health systems around the world. And it's spread without our intention. We have IHI has no support to do this. It's not, materially, there's no economics in it for IHI, but it's just organically spread to 14 other nations around the world. And so this notion of building a movement, Terry's vision of getting almost every older adult treated in some way is starting to come true for what we're trying to do. But let's rewind from this for a moment and just talk about this in the beginning. Because I think, although that's the end result, what I really want to talk about is how did we get there, right? What did this feel like in the beginning? How might you, as you think about your programs and your work, whether at SCES or in your own organizations, what might the lessons be for how you might scale and spread your interventions to reach everyone that potentially could benefit from them? So this is what it felt like in the beginning. And it's interesting because I, in fact, knew the dynamics around spreading and scaling things, but I still acted this way. I still planned obsessively. I still was sort of frenetic about why people weren't doing the things that I wanted them to do. I still was sort of frustrated about the notion that, when things didn't happen the way that I wanted them to happen, I still was sort of casting blame and demanding more and being a bit defensive. And I think in the end, what we were really experiencing fundamentally, all of us on the age-friendly team, there's about 5 of us that were the sort of the nucleus of the team. I think all of us were just afraid that we would fail our grandmothers, afraid that we would not do the job that we had been asked to do. Fundamentally, I think that's what was happening here. And I like to say that, the future's already here, but William Gibson said this in a novel, the future's already here, but it's just not evenly distributed. It was very unevenly distributed at the time. And what we were asking ourselves was this. We were asking ourselves this question at the time, which was, why can't we get all these people that we were working with, the hundreds of agencies and organizations that we were working with, to do what we wanted them to do? Right? That was the question that we were asking. It turned out that that was the wrong question. And the reason I know that that was wrong, or when we were in the middle of this, I called Joe McCannon. Some of you might know Joe. Joe was the campaign manager for the 100,000 Lives campaign, which was a big patient safety movement that took place in the early 2000s. And Joe, who had gone on to DC to work in the Biden administration, Joe said when he heard what was going on, when this was all happening in the fall of 2016, winter of 2017, he said, "You're asking the wrong question. The question you should be asking is this one: how can you get all the people that you want to do things to do what they already intrinsically want to do, right?" And because all of the people and he was right, because everyone that we were working with, all of the agencies, all the area agencies for aging, all of the governmental organizations, all of the NGOs, all the nonprofits, all the health systems, all of the people that we were trying to convince to do things in the 4Ms and in the age-friendly way, already wanted intrinsically to take better care of older adults. They already intrinsically had it. It was in their strategic plans. It was in their annual reports. It was in all of their planning documentation and otherwise. But we just weren't working with them correctly. We weren't asking them what they wanted to do so that we could incorporate it into our effort going forward. So when we started to do this, we started to unleash what I would describe as the intrinsic motivations of all of the people around us. And it turned out that this was the key to going from first innovation, from 0 to 1, to few to many. Like the essence of going from the beginning point, just getting to the first step, to getting to many, it was to actually unleash the intrinsic desires and motivations of the organizations and individuals that we were working with. They had to all name their grandmothers. And we actually started as a ritual in the age-friendly health system work to always start the meeting, which is kind of why I did it here, start the meeting with your story, whatever it might be. Because we could talk about data forever, but the true intrinsic motivation is not the tens of millions of people that are not having the kind of care that they should have. The true intrinsic motivation is to do it for a family member or a friend or a colleague or a spouse or yourself, frankly, at some point in the future. So the first principle of large-scale change is this one, to unleash intrinsic motivation. And the way to do that is through story. And there are two aspects of that story. And I did it actually here live with all of you just a few minutes ago. The first is to demonstrate that the status quo is untenable, right? The story of my grandmother is the story of an untenable situation, right? The other part of the story is to make the future state attractive. The other part of the story I told you, the second story I told you, was the story of my mother-in-law and the future state of a doctor driving a patient to, cross state lines, I guess, to go get care, right? It's this combination, this tension that exists between the present state being untenable and the future state being better, which is where that is the crucible in which intrinsic motivation is found. And it is like whenever you're doing your work to try to create motivation and movement, positive directional movement in your effort, this is the recipe to starting to tap into that intrinsic motivation. The second aspect of this is setting aims. You will have seen in our description of the goals that there was always a how much by when aim. This is a sort of standard IHI playbook component, which is to set a goal and have the goal be perhaps unachievable. And the reason to make it unachievable is that it stretches you. It's just sort of like if any of you are exercisers or runners or weightlifters, you know that you're supposed to kind of run a little bit past your capacity. Tempo runs are designed this way, if I remember from like how it was back in the day. And the whole idea is to stretch yourself a little bit, to kind of push yourself to a slightly uncomfortable place in order to learn something about yourself and about how your body will work. So setting bold aims, 1,000 in a year was our bold aim at the time, and then 2,500 in 2, and then so on and so on. We were always trying to stretch ourselves, to push ourselves to do a bit better. Don, mentor, colleague, friend to probably many in this room, but Don famously in his speech announcing the 100,000 Lives campaign for patient safety said, "Some is not a number and soon is not a time." And I think this aphorism has stuck with me for forever, basically, because it's exactly right. Name a number that you're going after and name a time frame within which you hope to accomplish it. And even if you're wrong, you will have taken steps towards getting to that goal. Years before I was in South Africa, I was at the WHO, the World Health Organization, and we ran a campaign at almost the same exact time as the 100,000 Lives campaign with Jim Kim and Paul Farmer from Partners in Health. And that campaign was called 3 by 5, treat 3 million people with HIV infection in sub-Saharan Africa by 2005. At the time, there was only 40,000 patients on antiretrovirals, and the need was almost 4 million people to be treated. And so we went from 40,000, and we put this goal of treating 3 million by 2005, not all the way to the goal, but pretty close. And we didn't get there. In the 18 months that we worked on this, or 20 months or so that we worked on it, between 2003 and the end of 2005, we got to 2.78 million people on treatment. And the interesting thing about this was the WHO and the sort of global public health press raked us over the coals. They were like, you didn't get to your goal of 3 million people. We were like, there was a 68-fold increase in the number of people put on treatment in sub-Saharan Africa. And this is called not a success. It was, by the way, if you look at all the documents, this is sort of my remediation around this, is that if you look at any graph of treatment of HIV infection in the world, between 2003 and 2005 is literally the definition of an inflection point. If you look at it, it goes from flat to like this hockey stick thing, right? The joint of the hockey stick is between 2003 and 2005. That's where the change happens. And after that, it becomes an unrefusable part of the public health agenda globally. So some is not a number, soon is not a time. Set a goal, pick a time frame, and then go after it. And the corollary to that we wrote in this white paper, which is that aims, this is the value of a bold aim statement. Aim creates strategy. It's not the other way around. I always thought it was the other way around. Like you put the aim in your strategy kind of thing. Like you write a strategy and part of it is your aim. It's the other way around. Aim creates the strategy. And then the strategy creates the result that you're trying to create. And the other thing we learned as we were doing that is from Dennis Wider. So as we were doing the patient safety campaign at IHI, Dennis, who was at CMS at the time, said this, which is, I think, so brilliant and so wise, because we are a culture of distraction in leadership, right? And Dennis's point here is, the main thing to do is to keep the main thing, right? It's sort of like a kind of hilarious way of saying, stop being so damn distracted, right? Like, focus on what you decide to focus on and stay there, right? Like, pick the thing, pick your number, pick your time, and relentlessly pursue that until you're done, right? When you're done with that time frame, you can shift your attention to something else. But for the time that you've picked, whatever that time frame is, that is your main thing. And that is the only thing that you go after during that period of time. So this is a ruthless prioritization, I suppose, from Dennis. The third is maybe my favorite. I like the other 5 or 6 of these things, but this may be my favorite, which is the idea that you have to engage reality and do it quickly. So I think when I was at WHO and for a period at CMS, the whole instinct is to plan everything out in a boardroom. That was my instinct, right? Like planning obsessively was like the #1 thing in my period of frustration as we were getting started. I think our instinct is to write plans, to create documents in rooms not unlike this one, right? Maybe it's a little nicer, or this is pretty nice actually. So, maybe it's a little smaller is what I meant to say, and making plans in a somewhat more intimate room. I remember when we were doing that treating 3 million by 2005 thing at WHO, I was in Tanzania in Dar es Salaam, and we were sitting at 2 tables like this writing the national plan for HIV in Tanzania. And it was exactly what I'm describing. We're writing the plan in a boardroom, right? Not as nice boardroom. But the essence of this is that nothing actually, whatever plan you have will meet reality and it'll crash and burn almost immediately. Like that is the essence of what we've learned over time with any kind of large-scale planning, large-scale change effort. And so the faster you engage with reality, what Brian Stevenson calls getting proximal to patients, families, communities, community members or beneficiaries, whatever you might call the people that you serve and work with, the faster that you get to them and engage with their reality, the better off you will be. And my experience of SCES, and I'll tell you a story about a client later on, is that you do this exactly. Getting into people's homes. The best way to engage reality is to get into somebody's home, and if they'll let you in. Because that is the fastest and easiest way to really understand what's going on. And you guys do that, I think, intuitively at SCES, but it is vital. Because when you do that, you start to do something that I think is sort of really, really important, which is that instead of your plan and operating your plan, you do something different. You play jazz. Now, how many of you are musicians in the room? God, come on, guys. There's like 3 of you in here. All right, fine, okay. So those of you that have ever played like jazz will know that there's a big difference between jazz and sort of classical or other forms of music. And the primary difference between jazz and some of these other music forms is that jazz is designed for improvisation, right? Is designed to allow local adaptation and creativity and fluidity. So you create a baseline beat and a rhythm, and then all of the instrumentation that happens on top of that is sort of done almost free form by the different players in the system. So it's not totally arbitrary. It's following something. It's following a pattern. You're following a beat and a rhythm, but the beats and the rhythms are understood, and the improvisation happens on top of that. But instead of when you engage reality, you start, I think, to play jazz. And so that's the notion here of engaging reality quickly. The fourth lesson of large-scale change is this one, which is about community dynamics. The thing on the right is Everett Rogers' diffusion of innovation curve. Some of you have probably seen this, but the whole idea here is that there are different, in any community, there is a distribution of people in that community and their desire to adopt a particular change. So when you're trying to create change in a whole community with thousands of individuals or organizations, they're going to come to you with different starting points, at different starting points. Some of them will be super innovative. You'll be right at the door. These are the people that when Apple announces some newfangled device, they're like standing in line to get the iPhone, right? Those are the innovators, the kind of people that you want to see earlier, or they're part of the early adopter community. And then you've got the early majority, late majority, and eventually what Rogers called the laggards, people that don't want to adopt something. It's important to know that these are not sort of categorical descriptions of humans, right? You're not an innovator and a laggard in everything. Innovator in everything, you're not a laggard in everything. So for example, I use this example a lot, that kids tend to be laggards with food, right? That like my kids don't really love spinach. They are like laggards with spinach, but they are technology fiends, right? They'll pick up whatever device is lying around and attach their face to it and spend the rest of the day in it if they were able or allowed to. So they're kind of innovators here, but they're laggards with sort of food adoption. The point here is that you're not one thing or another. You're not always an innovator or always a laggard, but with respect to the change that you're trying to create, better care for older adults, in a community, you will have a distribution of interests. And the more important point is that what it matters to the innovators and early adopters is sort of fundamentally different than what matters to the majority. What matters to the community of innovators and early adopters is the concept of scarcity, the idea of belonging to a community of other like-minded individuals that also want to do that thing, right? So if you're an iPhone person, or whatever, you're a technology adopter, you will want to be with other people who are also technology adopters. If you are a chat GPTer, you will want to learn from other people who do that on a regular basis. What matters to people beyond that early adopter innovation curve is social proof. You want to know that the people that adopted the iPhone didn't fall on their face and have it blow up in their pocket. You don't want, you want to know as an early adopter, or as an early majority or late majority, that the people that adopted the change are succeeding with that change, that they are getting better value from it, that they're achieving material benefit from it. So what matters to the majorities are social proof. What matters to the early adopters is being part of a community of creatives that they self-perceive as being like them, similar to them, or part of who they are. When we did age-friendly, this individual, Lil Blanchero, we knew this dynamic going into it, so we selected a group of diverse organizations, not exactly knowing where they would fall on this spectrum, right? We just knew that they were diverse in nature. We didn't know if they would be early adopters or innovators or exactly where they'd be. Turns out that the earliest adopter of age-friendly, the first adopter of age-friendly, the most innovative was a small community hospital in Eastern Maryland called Anne Arundel Medical Center. And a hospital is a big place. So when you think about who the actual driver was of that early adoption, it was this lady, Lil Blanchero, a senior nurse director in the aging unit in this hospital, in this community, in the eastern shores of Maryland. And we had no idea that it would be her, but it was her. This was the person that was the first adopter of this notion of age-friendly. And she deployed the first instance of the 4Ms anywhere in the country in her service unit in the hospital. And when she did that and showed the benefit of it, all these other people in her own health system came along, and they even made T-shirts, which I thought of like, when she made the T-shirt, I was like, okay, we've crossed the barrier between innovators and early adopters and the early majority, because this is what people wanted. So the point here is that every change, whatever the change is that you're trying to put forward, whether it's age-friendly or aging services or social and community health integration, whatever the change is, it will need some form of understanding. You almost need to do sort of a community mapping exercise of where people fall on the spectrum. And know that you'll be wrong. You might not know who the actual innovators are or the early adopters are, but be prepared to find those innovators and early adopters and then do what I'm doing right now, which is put them on stage. Lil would be on stage here. If this was purely an age-friendly meeting, we were trying to encourage all of you to adopt it, Lil would be here telling us the story about how she would be creating social proof for all of you to understand how she succeeded with age-friendly and why it mattered to her patients and her family members. The fifth lesson here is avoid theory lock, which is a kind of critical lesson that we've had to learn over time. I will say that this is probably the biggest mistake that policymakers make. So for those of you that are in the room that are policymakers, this is the one that I saw a lot when I was at CMS and a lot at WHO. We get obsessed with the solution, whatever the solution that we think is going to work most. And it's almost always categorically wrong. So if we think about this, if the question is like, how do we go from wherever we are right now, whatever we're doing with health and social care integration or care for older adults, and we want to get to this future state, like the kind of one that I painted with my mother-in-law, where everyone gets treated the way that she gets treated. The question is sort of what belongs in the middle? What will take us from here to there? And the most common thing that we hear a lot about is we need to teach people things. We need to train them and we need to educate them. And so we put forward grant proposals to secure X number of tens of thousands or hundreds of thousands or millions of dollars to train people to get there. And training may very well be an important part of it, but it is likely not the only part of it. Policymakers love this one, classically. We just have to get the incentive right. Those of you that worked on the ACA or here in Massachusetts worked on a version of it, the predecessor to the ACA, will remember this story. It was like, and when I was at CMS with Don, it was just if we could compose the right at CMMI, this was the early days of the Innovation Center. The whole thesis of the Innovation Center was essentially if we could just tweak the payment model slightly to make it work, it'll solve all our problems, right? That was like the way to solve it all. We just get the incentives correct, it will solve all these issues. And these days, it's like, can we just do that? Right? Can't ChatGPT just solve all of our problems already? And the notion here is that all of these things are probably useful, but none of them on their own will solve the problem all the way, right? And the more likely situation is to get from here to there requires a few hops. There's a knowledge hop, there's a motivation hop, there's a behavior change hop. And there's a variety of approaches that one needs to take to getting from here to there. And there isn't a single way of doing this. And in fact, it's not even a single way of doing awareness, or a single way of doing will, or a single way of doing behavior change. It's some combination of all of these things. And if I mapped exactly what we were doing with age-friendly, if I mapped exactly what we were doing with age-friendly, it would actually be a significant number of these sub-bullets under each of these things. It was never one thing, or two things, or three things. It was probably a dozen things that we were doing at any given point in time. So a lot of things to do to get to, as we say, there are many ways to many, and this is the way to think about that. One thing that was important for us in age-friendly was to build equity into the very beginning. This is fundamentally important for all of you here because of the dynamics at play in Cambridge and Somerville. The dynamics demand equity be built into the fabric of what you do, and I think SCES, more than most, has thought through exactly how to bring services that matter to ethnically diverse individuals right from the beginning. It's baked into the fabric of how you think about it, but a lot of people don't think about that. So in the many ways to many, there are many aspects of the many, right? And part of it is the diversity of the populations we try to serve. So building equity into this and making sure that what you do can actually get to all of who you're reaching is really critically important. Getting closer to the end now, the sixth idea here of how to get to large-scale change was this concept that we called affectionately the candy wrapper model, from candy as it used to be. And in this idea, the whole concept here was to, when you're implementing any change, when you're implementing an intervention around mobility or mentation or medications, be tight on the purpose. You're not relinquishing the need for a specific aim, Be tight on the evidence, what will actually change, bless you, what will change the nature of what you're trying to accomplish. Be tight on the aim and the evidence, but in between, the ability to use whichever of those levers that I just showed you a moment ago, to build awareness, to create motivation, to create behavior change, you can use a plurality of those mechanisms to actually create what matters most to your patients and families. So don't get locked into a single prescriptive way of doing things. This is a sort of common failure of academics, right? I tested something in my RCT. The intervention looked exactly like this. You must do exactly that thing, right? Otherwise, I can't say that you're going to get the same kind of result. And the answer is, and that may be true, you might be able to replicate that result, but context varies. The situation changes. Your patients and communities live varied lives in varied communities. And so to give people the freedom to innovate and implement the 4 M's, in our case, heterogeneously, was vital to the success of the initiative. It's what made it sticky. Without that implementation, customization, that contextual adjustment, we would have struggled to do that. And then the last, or penultimate lesson was to lose control. And this freaked Terry Fulmer out. So Terry, who is the sort of the mastermind behind this, the inspiration behind all of this, when I told her that, Terry, the goal of our initiative is to lose control of it, she was like, what are you talking about? This is impossible to imagine. I'm a researcher. No, we will take your funding away. But she played along with me, and in the end, we completely lost control of this thing. 14 countries, we didn't go to 14 countries. They came to us. They found what we did. There were over 300 publications around this stuff, most of which we only came to know about because somebody sent us a link to something in the end. There were stories from South Korea, from Qatar, from Saudi Arabia, from Brazil, from Portugal, it turns out. There are stories from all over the world about how age-friendly was being implemented in those environments that we had no idea was happening. And so we understood that this was happening. I remember very clearly when we got our first set of papers back. Somebody sent us an academic publication from a journal in Portuguese from Brazil, which of course we couldn't read. But Google Translate did a reasonably effective job, sorry. But it mostly just proved to us that it was about age-friendly. That's about all we could get out of it. But I remember that we got that paper in mid-2017, so about 8 months into this process. And that's when I knew that we were starting to lose control. And that is the sign of a movement that's built for success. So when you start to lose control of it by design to a degree, you have launched, that's what the young people call virality or whatever. I don't know if we're truly viral in the way that is described, but it's this notion of losing control with intention because it is what means scaled change in a system. So these are the ways to get from where we are to where we want to go. And there's one last ingredient, which I'll share with you, which I learned from this book, which I would commend to any of you. Rebecca Solnit is a journalist, and she was sort of she has an interesting pathology that I don't totally understand. That's disaster chasing. So she goes after like terrible things that have happened in our world and to try to understand what happens after they happen, like Hurricane Katrina or a big earthquake in Haiti or the COVID pandemic or whatever. Like she specifically focuses on things that are terrible. And what she's trying to find out is like, well, how do humans respond to these terrible situations? And what she found is sort of interesting. There's lots of lessons from this book that are really valuable. But the most kind of interesting aspect of or at least what I found most interesting, was that at the heart of almost every one of these initiatives of scaled change was a phenomenon that was patterned across every single one of them. It was the hardest work that any of the people that she interviewed had ever done. The response to Katrina, the response to a hurricane, the Hurricane Sandy, the response to an earthquake in Haiti, the hardest work that people had ever done. But, interestingly, also the most joyful moment of their professional lives. And I think that's at the essence of what it means to do large-scale change really, really successfully. It's a combination of super hard work, exhausting, and at the same time, this kind of joy that you almost can't, you can't sort of escape. It's this sort of beautiful, life-giving thing. I'm sorry, it's hidden. This is too bad. This is the Red Sox winning in 2004. You all know this story, but another story of adversity. I put that in there because it reminds me of like adversity, brink of failure, and yet joyful success, et cetera. So to me, like, that's how I remember this particular one in general. But every one of these campaigns and stories that I've been telling you all came with these teams. And the teams, in the end, experienced the change not yet they experienced it as really hard work, but they also experienced it as joy, which I hope is a message that you will take from here. So my last slide for you is this one. And thanks to the SCES staff and community for allowing me the opportunity to meet Chris Hawley. Chris is one of your clients, and Chris is wonderful. There she is in the upper right corner there. And Laura is her caseworker. So Laura is a staff member at SCES, and I don't know if is Laura in the room? I don't even know if she is, but it's too bad. It would have been good to embarrass her publicly like this. But anyway, so Laura and Chris gave me an opportunity to visit with them for just a few minutes one day. And I learned about Chris's story. So Chris is a 68-year-old woman. She moved here 3 years ago, and she struggles in her life with some bipolar challenges, as well as upcoming, has glaucoma and needs surgery very soon. And she's had from a very, very early age, when I asked her kind of what matters to her, which is now like a fundamental question that I ask every patient and anybody I meet almost on some level. But when I asked her what mattered to her, she said, my health. And I was like, okay, like, yes, I know I'm a doctor, this is, but she was like, no, this like really does matter to me a lot. It's mattered to me my whole life. I grew up, she was an adopted child, and her adoptive mother suffered from colon cancer at a very early age. And so Chris experienced her adopted mom going through this like horrible series of health-related catastrophes as she was growing up. And it left her with this notion that all we have is our health. And so when she was asked, as she was graduating high school, I think that's her picture in high school, which she also sent us, when she asked us about when she was asked at that age what mattered to her in high school, she said, she said the number one thing, even at that age, was health, was her health, because that's all we have, right? And so she's had that point of view her whole life. As she's grown older, it's been harder to have her health, right? It's been harder to maintain her health. She's had new needs. She needs housing. She told us about her experience with Section 8 housing. She was really grateful that her Section 8 housing came through earlier this month. It had just been a week or so since it had been granted or renewed, and she was relieved that it had come through. When she needs to get food and the weather is bad, she can walk there when the weather is decent, but when the weather gets bad, she can't get there on her own. And when she needs food, she needs help. She needs the Meals on Wheels program to come deliver her food in her home. So Chris needs a lot of things as she's gotten older. And for every one of her needs, she cites Lara. So when she needs to get to the market basket, there is Lara. When she needs to get help after her surgery, there's Lara. When she needs to get help with her stairs, because her stairs were causing her she was sort of miscalculating landing and potentially at risk for a fall, there again was Lara. Lara is everywhere she needs her to be. And when she found out that Lara had 95 other patients, I think Chris was like, what are you saying? Actually, she literally couldn't believe that Lara had 95 other people like her in her life. Because for Chris, Lara is everything. Lara offers her every single part of what she needs to get through her day. And she is never alone. She said this very clearly. When you're alone, you can ruminate on whatever is going on in your life. But I'm never alone because I have Lara. So that's what you guys are doing. That's what you're building, one person at a time with Chris. And it's magical when you do it. But we need a lot more of this. We need a lot more of Lara helping Chris in this world. And unfortunately, we're going to need even more of it in the future. So back to my running coach for a second, when he said to me at the end of our training that almost everything that you do in your world, you'll find there's plenty of obstacles in front of you, but the only way to do this work is to start by starting. Find your start line and get going. And I hope that you will do the same and that you will have success and scale in the work that you're doing because the world needs you. So thank you.